Welcome back to Real Talk with Susan Stone and Kristina Supler. We are full-time moms and attorneys bringing our student defense legal practice to life with real, candid conversations. So everybody out there listening to this podcast know that this is Susan, and my daughter got married this weekend, and I'm a little tired, but
though you think everyone knows that, everyone doesn't actually know that.
I know, but I felt the need. This is real talk. Guys out there in listening land, I am exhausted. But I had to come into work today because I knew that we had the recording of this podcast. And we're going to talk about pediatric health for the I told you I'm tired, BTQ plus community. And Kristina, I just want to have a conversation about the health need and not a political conversation.
Yeah, I'm really looking forward to today's episode because I think there's so much to talk about and learn to have more real conversations about the issues versus some of the politicized language that has pushed people into corners and people in many ways shut down and are not open to learning new information.
And I think we're just forgetting that we're still talking about kids. So why don't you kick off the guest so we can just launch in and talk about whatever the health needs are of the kids. And guys, let's leave the politics out, okay? For once.
Today, we are really happy to be joined by Dr. Michelle Forcier, who is an associate professor of pediatrics and an assistant dean at the medical school at Brown University. And with extensive training and experience in adolescent health and sexual health care, she's dedicated her career to addressing the unique needs of the LGBTQ plus youth.
That is the guest we needed for today's podcast. A doctor. Perfect.
So let's jump in.
Let's just jump in. So Dr. Forcier, can you explain exactly what you do for that population?
I have been a pediatrician for about 25 plus years, and I've been providing gender, sex, and reproductive justice care basically across the lifespan for this period of time. And it's been a pretty exciting community, a pretty wonderful and satisfying community to work for and to work with. And the way I look at providing care for the LGBTQ community is that it really is primary care. Basically, gender and sexuality are part of human identity, and they're there before we leave the womb. There's a neat study about in utero masturbation, which is kind of cool. So we get started early and we are gendered and sexual persons until we die. So if we look at gender and sexuality as being a ubiquitous part of the human experience, and we look at biology as absolutely diversity as a part of biology, it's one of the basic tenets of biology, then we understand that both sex and gender are going to be diverse experiences for a range of different people and folks. And my role has been to provide care for some of our most marginalized community members, which is the LGBTQIA plus. Sometimes it's easier just to say rainbow population.
I like that.
Before we dive in further, just to get some terminology nailed down for our listeners who maybe aren't as familiar, you've spoken about gender and sex, and we're referencing the plus, but can you just define those terms for our listeners, particularly the plus as well?
Sure. For many, gender has been considered in this very binary traditional way of male, female, or heterosexual and homosexual. Sexuality is about who we love and who we're attracted to and who we have different sexual behaviors with. Gender is who we are. It's a part of our identity in terms of being masculine, feminine, non-binary, and all the other ways that we can express a gendered self. And the world for many years has been pretty limited in terms of only discussing these binary identities. I think with time, with improved social discourse, with the advent of the internet and increasing knowledge spread in diverse ways and diverse communities, we understand that there are many, many ways to be sexual and many ways to be gendered. So the L stands for lesbian, which are persons, we might say women who are attracted to or have sex with women. Gay usually is referenced to either males or females who are attracted to the same gender partner. Bisexual historically has been the term for people who identify as being attracted to both males and females, but now we have even more inclusive terms, which are things like pansexual, which means gender doesn't factor into who I'm attracted to. Transgender or gender diverse are persons whose gender identity doesn't exactly match the gender they were assigned by their parts, chromosomes, or hormones at birth. I is another initial for intersex, or persons who have differences in sexual development in the parts and organs they were born with. And A can mean asexual, or persons who really don't have a sexual affinity or an interest in sexual activity. Allied, and this plus means there are probably a million different ways, and we know there are a million different ways people may identify in terms of how they see themselves as a gendered person and their gender expression and gender role and gender self in the world, as well as their sexual attraction, their sexual behaviors, and their sexual identity in the world.
That's a lot. That's a lot. But
It's
here's
messy.
something that comes into my mind because you are a pediatrician. How do those differences make a difference in terms of just treatment for well visits? What type of care is specific and unique to that population as opposed to what I would call a heteronormative child?
Sure. To be honest, in any visit, and again, whether it's children or whether it's adults, we should be talking about these aspects of selfhood and behavior and health needs across the lifespan. Of course, we should do it in a developmentally appropriate way. So if we're going to talk to a 6-year-old about their gender identity, we might ask them, what is it like to be a boy or a girl? How does that feel to you? How do you express boyness? How do you express girlness? For a 16-year-old, that may have very different words in terms of how do you view your gender identity? What parts of it are comfortable for you? What parts are not comfortable? Do you have any questions? Again, the same with sexuality. Who might you have a crush on versus a full sexual history for a later teen or young adult who's sexually active with one or more partners? So it's all about, again, using the language of the patient and understanding where they are developmentally to continue to talk about these aspects of both selfhood and wellness during health visits.
Well, I guess I want to press you on that because I'm a mother of 3, and I would say for the first 14 years of checkups, it's, height, weight, vaccinations,
Poking and prodding.
talking about school and milestones. I mean, really,
Or at least that was your experience with your children's pediatrician.
yeah, but I just don't, I don't think conversations regarding sex came into play until when making a decision about the HPV vaccine, or maybe when does menstruation start for that being the end of growth. I guess that's what I'm confused, or birth control when that comes in. But other than that, I think of how big is the baby?
Well, and I'm thrilled that you ask about this because what I'm proposing is a slightly more advanced model of care in the sense that, again, if we know that there is gender diversity in the world and some youth present as gender diverse, gender exploratory as early as 4, 5, and 6, shouldn't we be talking to parents about, say, again, educating people? Your child is assigned male or female at birth, but we don't know what their gender identity may be later down the line. And that's the 1 or 2 sentences that a pediatrician can have with a parent to, again, describe and educate the difference between an assigned gender at birth and the fact that potentially 2 or 3 and probably more percent of the population of young people are going to be exploring gender, or at least talking about it over time. Then when we know that many youth undergo puberty and it's considered normal as early as 7 or 8 years, You can start having breast buds by age 7 or 8. It's considered within the normal range. You can be having a period by the age of 10. So if you're waiting for the magic number of teen years, 13, you've missed a whole bunch of folks that have already started many of the stages of puberty and actually may be completely adult in their hormones and progressing toward adulthood very quickly in terms of their bodies. So by waiting till kids are teens, until quote unquote, they're ready to be sexual or ready to go through the process of puberty, we've missed the boat in preparing both parents and kids for helping their children approach adolescence, approach the changes of puberty, approach the concepts of being a gendered or sexual person in a healthy and supportive way. Think about it. Wouldn't it be easy as a parent or easier as a parent to talk about sexuality when it's theoretical versus you're coming in because your daughter's pregnant and you didn't even know she was having sex? I would prefer to talk with kids in a developmentally appropriate way over time so that kids are prepared to make decisions and that we're not going back and saying, okay, now we need to deal with an issue. Now we need to deal with a problem. Now we need to deal with some sort of health need versus let's talk about anticipatory guidance. Let's have our kids be healthy.
I know that you're involved in giving T blockers or hormones.
Oh, I was going to ask about that.
Yeah, I'm really curious. When do you decide that's appropriate? What are the side effects?
Are they safe?
And are they safe? And also, how do you know, and this is a lot, that a child just not playing with identities and trying on what suit fits because there is discussion versus this is real and we need to act?
Sure. So we know that gender play, trying on identities, is common among kids. It's how, again, we explore and figure ourselves out. But every kid that plays with their gender identity and gender roles and gender expression doesn't get hormones and doesn't go to a clinician to go get hormones. So if a child is really thinking hard and long about their gender identity, and oftentimes they'll think about it quite a bit before they even talk to their parents, they will have that conversation with their parents about maybe the gender they were born with doesn't quite fit them, or maybe it absolutely doesn't fit them. And we have kids really at young ages, just like they know their cisgender identity. We have some kids at very young ages know their transgender identity. Regardless, as a parent, in some ways, it really shouldn't matter what their gender identity is. What you want is to create a home situation, and ideally, again, an early clinical situation where kids and parents have lots of information so they can explore gender in whatever ways make sense for that child in a safe and healthy way. If you look at the studies by Kay Olson, the Trans Youth Project, she shows that kids that grow up in supportive environments, kids who present early as gender diverse and exploring gender identity, she demonstrates that they look just like their cisgender peers in terms of anxiety and depression growing up in supportive households. Now, a supportive household doesn't care. The endpoint is a happy and safe child. It doesn't matter which direction the child goes in terms of gender identity, because as an accepting and loving parent, I don't care what their gender identity is. I want my child to be authentic. I want my child to feel safe. I want my child to feel loved. I want my child to feel heard and respected. And it doesn't matter what their gender identity is. They're my child.
Is there an average age when the research shows children start to explore gender identity and conversations are starting to be had within households, or is it different for everyone?
Different for everyone. I've had 80-year-old patients come to me and say now is the time that they're ready to start their gender affirmation process.
But I do want to press back on the question because there are parents who do want, to help their child.
Yep. Good.
Hormones are a health option. And I think Kristina's question was a good one. When does a physician how does a physician and when does a physician make a choice that this is appropriate? And are they safe?
It's not based on age. It's based on need. And so a patient will go through a very thorough evaluation. People don't just walk in clinic and get a shot of puberty blockers. People
What do
make
those evaluations entail?
long history about home, about activities, about the family medical history, their medical history, their social history, substances, self-harm and mental health issues, exposures at home and school.
I assume questionnaires are given to children and parents as well.
It depends. And I mean, I find that most kids would rather talk to me than fill out a piece of paper.
Yeah.
So we
So
talk.
if you make the decision that it's appropriate, what are the benefits and what are the risks?
So the benefit, again, just remember, we're not having the same conversation about, say, kids that are using the same medication for precocious puberty. Again, just to remind yourself in the context of avoiding political chatter, same medicine, kids not talking about it at all. So these are very safe medicines that have been around for many, many years. And we've used them and first studied them with precocious puberty. Again, completely reversible.
Well, because is it true, doctor, that precocious puberty, which just for our listeners who don't know what that is, that's the onset of puberty very, very early at life. And we want to delay that as much as possible because they're now finding that, especially for females, you want puberty to go in later and menopause to be later.
Well, you want puberty to be later for a couple reasons. Number one, it would be really, really weird to have a fully feminized body at age 6.
Horrible. Yeah.
So there's social as well as biological consequences. And these kids use puberty blockers far longer than many of our trans kids. Again, without all the brouhaha about safety and effectiveness. So puberty blockers basically are a hormone analog and they fool glands in the brain to shut down and stop secreting the hormones that trigger ovaries and testes to secrete testosterone and estrogen, the sort of puberty hormones that start to create adult body and adult sort of physiology. And by putting this temporary pause on those brain gland signals, the ovaries and testes just sort of rest, they stop secreting. And when we take away that hormone, the ovaries and testes start secreting again. So it's sort of like putting a pause button on your Spotify or your music player. Pause, lift it back up. The music starts right back where it was. It just has a delay in time.
Have children ever gone back and forth and said to you, they were on the medication and then said they changed their mind? Or do you see that when kids are evaluated, you make that choice, they're happier, more fulfilled, and they'll stay on it long term? Or is it across the board?
It's across the board. As a pediatrician, we want to keep asking kids, is this the right path for you? Should we be doing this? Does this still help you figure out who you need to be, where you need to go? Or have you figured some of these things out and don't need puberty blockers anymore? Or have you figured these things out and now need gender hormones? It all depends on the child. So our job is not to push someone forward through gender hormones or puberty blockers. It's to keep asking kids, what do you need? That's medicine 101. Patient,
Sure.
What do you need? Where are we now? Things change in our body. Things change in our heart and mind. We have to keep talking and listening to kids to find out what they need. So if they need to stop, they should. And if they need to start again because stopping actually demonstrated that they are really uncomfortable with the changes of puberty, then yeah, we can honor that request and honor their experience.
So what are some of the risks though that can be attendant to taking these hormones?
Well, the way I tell kids and parents, having to come to the doctor to get a shot kind of stinks. So that's a risk and that's a bummer. Let's see. If kids start these medicines very early in puberty, there's very little change in their internal hormone environment. So they don't have side effects like, say, menopause, some hot flashes and some little bit of irritability as hormones are shifting.
Is growth impacted?
Growth usually is
That's a great question.
impacted in the sense that trans boys may have the potential to grow a little bit taller because we're going to block estrogen's effect on growth plates. And for trans girls, again, we can work with them to look at, again, their potential height or their height trajectory to figure out how tall they are going to be. And will that factor into, again, starting estrogen or gender hormones? So we can use it again to inform our patients what their options are so that they can be in a body that's comfortable and safe for them.
Well, are those blockers different than gender hormones to help, let's say, in a trans, would it be a child who identifies as trans male wanting to be female? I hope, again, I'm terms right, and forgive me if I'm getting them wrong. So if you want to help someone develop the other way, or maybe a female by birth sex who wants to be a male, is that a different type of hormone or medication protocol?
So blockers are used basically just to stop the current gonads, ovaries and testes, from secreting estrogen and testosterone. If a patient is either way past the beginning of puberty, or a patient is on gender blockers, puberty blockers, they can start the other hormones, so in the past referred to as cross-gender hormones, to basically start the puberty that makes sense for them. So if I am identifying as female and I have been on puberty blockers at age, say, 13 or 14 or 15 or 16, whenever, again, that patient says it's appropriate for them, they have parent support, and we all have a plan, they may start estrogen so that they can develop just like their peers, which we think, again, has a positive health benefit in terms of, again, that congruence socially with my body is developing just like my friends. I feel normal. I feel accepted. I feel like I'm a part of my community. So for boys, puberty usually happens a little bit later. So sometimes they might start their male testosterone hormones a little bit later, say, than females. But again, it's all dependent on when we first see a patient, how far they've gone through puberty, what they understand of their gender identity, and where they are in terms of making a plan to affirm their gender identity or not, or just learn more and explore.
What do you say to parents who are in your office with the child and the parent, you can tell, just isn't on board with the child's desire to start hormone therapy or whatever the circumstance may be? What sort of conversations do you have?
Would that ever happen?
Never.
So yes, that happens quite frequently. We have parents that want us to say this is just a phase or a fad. Let me tell you, being transgender or gender diverse is hard in our culture. It's hard. And when we see kids in our clinic, the vast majority of the time, they're there for real issues, real goals, and real pain. And we need, again, to start with taking our patients at their word and carefully explore what they mean by their experience, their dysphoria, or their goals. So I tell parents, listen, you and I are coming from the same place. I want a safe kid, a kid who's around, alive, participating in the world, a kid who's healthy, who's mentally and physically healthy. We may come at it from slightly different approaches. You're coming at it as I expected my child to be cisgender and I want to walk them down the aisle at their wedding and they're going to have a baby and provide me with grandchildren. And my job as that child's pediatrician is to say, your child is telling me that their body, if it's to continue to develop, say, into a female body, is going to create such harm, such discomfort with their physical self, such anxiety and depression, because in their heart and head, they identify as male. And so we have to really listen to your child and hear what they say in terms of how do we explore the identity you were assigned at birth with the identity that you are telling me you experience now. And
when do you talk about surgery? When does that enter into the conversation? Because I think it's a very different conversation. When do you start maybe blockers or hormones versus when do you actually put a child through radical surgery that you can't reverse?
Most children don't go through quote unquote radical surgeries. In fact, children have far more radical surgeries for lots of other issues or problems, and they assent to the process of surgery for whatever their healthcare needs, along with the consent of their parents. So I think that's the first thing to take.
Well, some children I would say would want to complete the process, right?
But many children don't have necessarily the support or the resources to necessarily go through some of the more major and intensive surgeries. Vaginoplasty and phalloplasty, creating a vagina and a penis, very intensive. People don't usually do that until after age 18.
Okay, so it's not really a pediatric issue then.
No. Now, say there are some youth that this is the more quote unquote common surgery, although again, with blockers, we don't have to do this quite as often now, is say a child's developed breast at age 7 or 8, and say they identify longstandingly as a trans male. Why, when they come see me at age 16, or they come see me at age 14, and by age 16, their gender dysphoria regarding their adult-sized breasts, which they've had now for 8 years, is killing them. They're not showering. They're wearing a binder 24/7. They have suicidality. And again, nothing's changed in their gender identity. Why would I say you need to wait 2 more years until the magic number of 18 to have a male chest construction, knowing that nothing has changed from age 6 to now 16, and you have had 8 years of female breast tissue? That's harmful. The harm in that is far greater than the harm of saying, you're 16, you've been through years of care with us, you're going to be assessed by a surgeon. The surgeon may require other information before they do your surgery. And then through this long-standing process, not I come in the clinic and tomorrow I have my chest removed. Oftentimes, months to years, I get my chest surgery and I no longer have to wear a binder 24/7 and I can take a shower and
So
look in the
it
mirror.
can be a pediatric issue.
Yeah.
Something that a pediatrician, okay, that's all I wanted to understand. Is this something that pediatricians deal with versus not?
Not too often. And
Okay.
most of the time when we get to the point of surgery, again, there may be a number of people involved, including gender specialists, as well as including mental health people, as well as the team that works with the surgeon. So we're talking about a whole lot of people.
Dr. Forcier, can you tell our listeners a little bit, in preparing for today, we came across the term or mnemonic I'd never seen before, LARC.
I looked it up too.
How do you work with this population in terms of contraception? And tell our listeners what a LARC is. And
Because a LARC is not a bird, guys. It's an acronym.
No, and it's wonderful. It's a long-acting, completely reversible contraception. They are a little device we can put in the arm or an intrauterine device we put in the uterus.
So an IUD, right?
Yeah, exactly.
Okay.
They're so effective in terms of preventing pregnancy. Now, we know that young people may not identify, they may identify as straight, but they have either same-sex relationships. We also know that young women who have sex with women are actually at increased risk for STIs and pregnancy because they're not prepared.
Wait. So I was going to say, if you have a child who tells you that they're interested in only sex with their own matching sex, not gender, because that can be an identity issue.
Yeah.
You know what? I have to be honest with you, doctor. I would think, why do I need to go down the contraception path?
Because the data says that young women who have sex with women get STIs and get pregnant.
Well,
Because they're
but wait. But long-acting LARCs won't prevent an STI. Only condom use, correct? Or dams
only
or
not having
barriers.
sex will prevent STI.
Yes. But given we all know, we can all say that, but we are in the world and teens engage in sexual activity. I like the idea of a LARC in terms of you don't have to depend on taking that pill and memory. I got to be honest with you, though. It's not as good, though, in terms of STI infection prevention, is it?
No, its purpose is not to prevent STIs. It'd be like asking your microwave to show you a TV show. Your microwave isn't going to play Netflix. It's a device for a different purpose. So we need.
So I feel like I'm
to
missing
talk about them
something.
as separate pieces.
Help me out. Help me out. I'm getting
I don't know. I'll ask the dumb question. So, I mean, it's essentially an IUD.
What's essentially an IUD?
A LARC.
Well, no, there's one that goes in the arm, and there's one that goes in the uterus. There are different kinds of long-acting
I was confused
reversible.
too. Thank you.
Got it. So it's just about the location. of the
Some
implant.
young people don't want people putting things in their uteruses. They don't want a pelvic exam. They're freaked out. And
Sure.
so that little rod in the arm that suppresses ovulation, wonderful, very effective, very easy to put in and take out. Nice.
So it's really about patient comfort and what the patient is more open to.
Shouldn't that be patient care 101 anyway?
Yes, but we still need to insist that students are mindful of using condoms or other ways of preventing disease. So what do you recommend? A LARC plus what?
I mean, number one, the literature shows that dual methods are wonderful, and especially dual methods of STI protection with some sort of barrier method or condom, internal, external condom, or again, a LARC in terms of a long-acting reversible contraceptive. So again, think about the story. You have a parent coming in and she's worried about her teen being sexually active, right? And she says, I don't want to allow her to have birth control, even though she tells me this is what she wants, because that's going to give her permission to have sex. Do you really think the parent allowing birth control gives that child permission to have sex? Or do you think that child's going to make that decision to have sex on their own?
You're talking to two lawyers whose whole practice is dealing with student issues. So, and I have to gather that people who listen to our podcast are well on the way of understand. I guess our questions are focused differently because really our parents all are very supportive of their students and their choices. We're very lucky that
by and large, not all of them, but by and large.
Yeah.
But I think the main thing is your kid's telling you they need something. And you may not agree with the fact that you want them to be sexually active. Most of us aren't super excited to think about like our 14-year-old being sexually active. But
not a 14-year-old.
But if my 14-year-old was sexually active, I would really want to make sure they had good birth control. And I would really want to make sure they understood things like consent, saying no, saying you need to use a condom, and walking away from that encounter feeling empowered and safe. We don't
advocacy.
Yeah. If we don't talk about sex and how to manage it, how are young people going to make thoughtful decisions and safe decisions?
What are some of the most promising not promising, pressing health issues facing the LGBTQ plus community today?
I thought we weren't going to talk about politics and legislation.
So I'm going to say health issue.
Health issue.
Yep.
Those are health issues, though, because those are about geographic and political access to care on a state-by-state basis.
So access
That's huge.
Yeah. Fundamentally, just it's not even so much the medicine or the science, it's access. Sure.
The science is actually a lot less exciting because the science is pretty consistent in terms of different types of availability and access to care for LARCs is really important. The safety of abortion, the benefits, short-term and long-term of gender affirmative care. The science, again, we're not seeing there's like a huge variance in terms of different outcomes in different studies. The outcomes are pretty consistent in terms of access to care improves outcomes in a whole host of these sexual gender health issues.
I have to tell you something. I learned something today because I learned a lot. I did not know what a lot of these acronyms meant. And I have to be honest with you. I like taking worries off the table. And I did not think you had to worry about pregnancy when you have a child. I thought that's a huge benefit is that's one issue off the table, or I didn't think about the STI issue. So I thank you for educating me.
Absolutely. I think that this has been a really good discussion with a lot of information for our listeners. And if parents out there, listeners, want to learn more about you or any of your research or any good literature, where would you direct them?
PubMed has lots of good information in terms of all the research, not just me, but all the research that supports sort of making these types of decisions. Up to Date is a nice summary of different information about gender, sexuality, and reproductive health care. I'm happy to come on with you guys if you ever want to have a question and answer session. This is really important stuff, and I'm really excited to talk science and to talk evidence and to talk about listening to kids. So I so appreciate what you're doing and happy to be helpful in any way.
Thank you. And I'm concerned. I can't imagine, doctor, how many doctors in your area are across the country?
I wish. Well, that's why we keep talking about this healthcare being primary care. Primary care, pediatricians, family medicine doc, nurse practitioners. We all should be comfortable talking about gender and sexuality because they're a part of our lives and they're a part of primary care.
Yeah,
So
I
we're
can
doing
tell
more and
you
more
we-
training.
Yeah, we do need more discussion about this because, like I said, when I think of a well visit with the child, I do think of weight, health, and the
Pooping and
meningitis getting.
Yeah.
So
My
thank you.
14-year-old did not want to talk about pooping and peeing. There were more pressing and more pertinent issues relevant to her life at age 14.
You need to spend a day at my house because pooping is an everyday conversation.
Okay, and I think it's time to wrap it up.
Time to wrap it up.
Dr.
Thank
Forcier,
you.
thanks so much for joining us, and we hope our listeners enjoyed this episode.
Thank
Have a
you.
great
Bye-bye.
day. Bye-bye.
Thanks for listening to Real Talk with Susan and Kristina. If you enjoyed this episode, please subscribe to our show so you never miss an episode. And leave us a review so other people can find the content we share here. You can follow us on Instagram. Just search our handle @StoneSupler. And for more resources, visit us online at studentdefense.kjk.com. Thank you so much for being a part of our Real Talk community. We'll see you next time.